Hello, good afternoon, ladies and gentlemen, dear colleagues. It's my pleasure to welcome you to this ESVS webinar, also on behalf of my co-chair, Professor Debus from Hamburg. And our topic today is improved revascularization. In fact, when we perform a peripheral revascularization, we always look for the best material, for the best technique to make that revascularization a long-term success. We select the most appropriate catheters, balloons, stents for the appropriate anatomical situation. And in bypass surgery, we select the best available vein, the best prosthetic material, and the best anastomosis technique to make it a long-lasting success, to avoid that the patient comes back in the middle of the night, with occlusion and with acute limb ischemia. So that's our topic today. To improve revascularization beyond blades and balloons. We have a very distinct faculty this afternoon. We have Professor Sebastian Debus. He's head of the University Heart and Vascular Center of the University in Hamburg, and he's also General Secretary of the ESVS. Welcome, Sebastian.
Thank you very much, Rupert. I had been the Secretary General until end of October. My term ended now.
And we have Professor Marianne Burtmann. She's the head of the Department of Angiology at the University of Graz in Austria. Hi, Marianne.
Hi, Rupert.
And we have Professor Marco Di Carlo. He is the Vice Director of the Cardiac Cath Lab and Professor at the University of Perugia in Italy. Hello, Marco.
Hi, Rupert. Welcome, everybody.
And to have this webinar as interactive as possible, please make use of the chat box. You will find it on your PC below the video or on your smartphone. Remember, if you want to use the chat function, you have to escape from the full mode to go there. Also, the same is true for the questions. Without further delay, Sebastian, I would like to hand over to you for the introduction and announcing the first speaker. Please, Sebastian.
Thank you very much, Rupert, for your kind introduction words. And due to the sake of time, we should start now our program. And I would like to introduce Marco Di Carlo now for his first talk on current guideline recommendations for antithrombotic therapy in peripheral artery disease, which will also include some cases and also multiple choice questions to keep the talk interactive. Marco, please go ahead. The floor is yours.
Thank you. Thank you, Sebastian and Rupert and Marianne. So it's a pleasure for me to start this webinar by showing you what current guidelines recommend about antithrombotic therapy in peripheral artery disease. Just an introduction. I want to tell you that I will use this acronym, lower extremity artery disease, or LEAD, instead of PAD, because in the guidelines in 2017, we decided to propose this new acronym because PAD, of course, it has been in use for decades and we are all used to it, but it generally indicates lower limb arterial disease. But in several instances, for example, even in the COMPASS trial, PAD also includes carotid disease. And sometimes it may also include renal, splanchnic, or upper limb artery disease. So for the sake of clarity, in 2017, in the ESVS guidelines on peripheral arterial diseases, we decided to propose this new acronym, LEAD, to exactly clarify what we are talking about. So, as you all know, guidelines are based on the available evidence at the time of the writing of the guidelines. So when we published them in 2017, we had a great number of trials in cardiovascular medicine dealing with anti-thrombotic treatment. But among all these trials, only one, the Euclid trial, was dedicated to lower extremity artery disease, while all the other trials included some patients with lower extremity artery disease, but only 4 big trials had a pre-specified lead subset, those identified with an asterisk. Importantly, the COMPASS trial was presented during the same Congress as DSC ESVS guidelines on peripheral arterial diseases, so its results were not included in the guidelines. And this is why we need to update this antithrombotic therapy based on the results of the COMPASS trial and the Voyager trial as well. So looking at the evidence at the time of the guideline publication, starting from patients with asymptomatic peripheral artery disease, lower extremity artery disease, we know from two trials, the POPADA trial as well as the AAA trial, that aspirin monotherapy is not beneficial in patients with asymptomatic lower extremity artery disease identified by a mildly abnormal ABI. On the other hand, in patients with symptomatic lower extremity artery disease, it is known, it has been known for decades that aspirin monotherapy reduces the relative risk of MI, stroke, and death by 20%. So aspirin monotherapy is recommended in symptomatic patients. Then we have the Capri Trial, which showed that the subgroup of patients with peripheral artery disease and specifically lower extremity artery disease were those who benefited most from clopidogrel versus aspirin. And that's the basis for the recommendation in the guidelines to prefer clopidogrel with a class 2B, that is, maybe prefer clopidogrel over aspirin in lower extremity artery disease. The Charisma trial randomized patients to either dual antiplatelet therapy with aspirin and clopidogrel versus aspirin alone, but the subgroup of patients with lower extremity artery disease had no significant benefit from dual antiplatelet therapy, so no recommendation for dual antiplatelet therapy in the general population of symptomatic patients. The Euclid trial explored the benefit of ticagrelor versus clopidogrel in patients with lower extremity artery disease, but it failed to prove the superiority of the newer platelet inhibitor ticagrelor. So again, there is no recommendation for ticagrelor over clopidogrel in patients with lower extremity artery disease. Coming to revascularization, as surgeons, you certainly know better than me, the BOA trial, which 20 years ago actually showed some benefit in terms of freedom from occlusion with vein grafts only, with VKA as compared to aspirin monotherapy. However, importantly, there was an increase in the risk of hemorrhagic stroke, a threefold increase, which is a very hard price to pay for the patency of the vein grafts. Similar results came from the CASPA trial, comparing dual antiplatelet therapy with aspirin and clopidogrel versus aspirin monotherapy. And you can see that only in patients receiving prosthetic grafts for below the knee revascularization, there was a benefit from a dual antiplatelet therapy. Once again, there was a threefold increase in the risk of bleeding with the use of a more aggressive antiplatelet treatment. So coming to the peripheral revascularization with the endovascular revascularization, we have a very small trial, the MIRROR trial, which compared 80 patients treated with aspirin and clopidogrel versus aspirin monotherapy. And there was a significant benefit in terms of freedom from TLR at 6 months. So in summary, in this figure, you see what are the antithrombotic therapy recommendations for patients with lower extremity artery disease. For asymptomatic patients, no antiplatelet treatment. For symptomatic patients, in general, single antiplatelet treatment with aspirin or clopidogrel with a preference for aspirin over clopidogrel. For revascularized patients, if in case of endovascular treatment, dual antiplatelet therapy for short-term treatment, and then single antiplatelet treatment. Finally, for surgery, single antiplatelet treatment, or in selected patients, we can use VKA, for example, in patients with infrainguinal vein grafts at high risk of thrombosis, or we can use DAPT for BTK prosthetic grafts. So I think I'm done with my first presentation, and I give the microphone back to Rupert.
Thank you very much, Marco. That was really a fast ride through the evidence that we have on antithrombotic treatment, and that's really the basis for the guideline recommendations. And now my task is to step beyond that and show new data and address the Voyager study. Is this a new era in antithrombotic treatment? Here are my disclosures. And I would like to start with reviewing what challenges do we face when we perform peripheral revascularization? If you look at these current data based on a large number of patients undergoing peripheral revascularization collected by Connie Hess, you can see that right after the revascularization, there's a high risk for the patients to suffer from major adverse limb events. There's a fourfold increase in acute limb ischemia, and also there's a long-term risk of major adverse cardiac events. And as you all know, if a patient suffers from acute limb ischemia, the outcome is really poor. So patients stay for a median in the hospital for 8 days, 8% short-term mortality, 20% undergo major amputation, a third of the patients have prolonged ICU stay, and 3/4 of the patients have to undergo major surgery. So the outcome after acute limb ischemia is poor. Now, what can we do with the antithrombotic regimen? And Marco, you just brilliantly showed the studies that we have, and I just want to repeat that. The CASPER study, looking at dual antiplatelet treatment versus aspirin alone in bypass surgery, was a negative study, unfortunately, but it increased the risk of bleeding. And again, you showed already the Dutch BOA study. Overall, that again was a negative study, and you pointed out already that the bleeding risk was greatly increased in that study. So the Voyager study set out to look at patients undergoing peripheral revascularization with symptomatic PAD and enrolled patients early after successful peripheral revascularization. And the objective was to look at the efficacy and safety of Rivaroxaban 2.5 milligram twice daily plus aspirin compared to aspirin alone to reduce thrombotic vascular events in those patients after revascularization. Remember, that dose of Rivaroxaban on top of aspirin was very successful in the COMPASS trial. It was a large, randomized, double-blind phase 3 trial, enrolled more than 6,500 patients, comparing Rivaroxaban plus aspirin against aspirin alone, but clopidogrel was also allowed in the patients up to 6 months. It was a long-term study, so the mean duration was 30 months. And it's interesting because for us, because Voyager used a new outcome which is very relevant to the vascular community, because it combined limb events, acute limb ischemia, major amputation for a vascular cause, with MACE events, myocardial infarction, ischemic stroke, or cardiovascular death, and the principal safety outcome was TIMI major bleeding. So patients were included if they had symptomatic PAD, successful lower extremity revascularization, and patients were excluded if, for example, the doctor decided that this patient would need dual antiplatelet treatment for more than 6 months, or if the patient had an indication for full dose anticoagulation. These are the baseline characteristics of the Voyager study. This is the group with Rivaroxaban. This is placebo, and it's a typical population that we see in everyday practice. A high percentage of patients with diabetes. Unfortunately, more than a third of the patients were still smoking. 20% had impaired renal function. 1/3 of the patients had concomitant coronary artery disease. And as is being used in clinical practice today, about half of the patients received clopidogrel on top of aspirin, and of course, if they were randomized to Rivaroxaban, on top of Rivaroxaban. The baseline treatment was good. 80% of the patients received a statin, and 2/3 of the patients received ACE inhibitor or ARBs. What kind of PAD was it in the patients? You can see that about 95% had a history of claudication. The ankle brachial index in median was 0.56, so it was substantial symptomatic PAD. And you can see that more than 20% of the patients had critical limb ischemia. And I think this is very interesting because of those 6,500 patients, more than a third received surgical revascularization. And we hear more about that from Professor Debus in a minute. And 2/3 of the patients received endovascular or hybrid treatment. The median time for enrollment was 5 days, and 25% of the patients were enrolled on day 2 or earlier. This is the primary endpoint of the study. And there are several things of note. First of all, it was a positive study, highly significant, reduced the risk for this primary endpoint with a hazard ratio of 0.85. The second thing that you can observe here is that the event rate, if the patient received aspirin only, and remember 50% also had clopidogrel, the event rate was very high, was almost 20% after revascularization, and there was a substantial absolute risk reduction translating into numbers needed to treat of 39 with the addition of 2.5 milligram Rivaroxaban. And also what you can recognize, these two curves separate very early, so it's an immediate effect that transfer in the long-term treatment of those patients. Now, what is the safety? What about the bleeding in this study? TIMI major was the main safety outcome, and there was a numerical increase of TIMI major bleeding, hazard ratio 1.4, but that was not significant. If you look at the very severe bleedings, intracranial hemorrhage, fatal bleeding, you can see that the number of these fatal and intracranial bleedings were low, and it was not increased with Rivaroxaban. If you looked at more sensitive bleeding parameters like TIMI minor bleeding, again, it was not statistically significant, but there was a numerical increase also with the BARC3 bleeding, hazard ratio 1.29. But if you looked at ISTH major bleeding, again, a hazard ratio of 1.4, that was significantly more with the Rivaroxaban compared to placebo. It's very interesting, and we'll hear more about that for the subgroups. This is a forest plot for the efficacy. And if you look at, for example, in those patients with critical limb ischemia, you can see that also the effect was the same, while the event rate with aspirin only was very high in those patients, was 24%. Also, you can see for the patients undergoing surgical revascularization, the event rate was higher, but the benefit was at least as good as in the overall study. This is efficacy. Now let's look at safety. Let's look at the same subgroups here, and you can see that with respect to safety, the bleeding was not different in the surgical subgroup compared to Rivaroxaban versus placebo. And again, there was no P4 interaction with respect to bleeding. A main concern of the doctors and the authorities was, of course, if you start with an anticoagulant drug right after the revascularization procedure, even on top of clopidogrel in half of the patients, how about the post-procedural bleeding? Now, this was very low. If you look at the take-back bleeds, that was not different between aspirin alone and Rivaroxaban plus aspirin, very low. And even during the course of the study, if a procedure was necessary, the take-back bleeds were low and not different between the two groups. So in summary, if we weigh the risk and the benefit over time, you can see there was an initial, yes, increase in bleeding. That was not statistically significant, but there was an increase. But there was a continuous benefit with reduction of thrombotic events in those patients, and that really carried on over 3 years, reducing the primary efficacy endpoint with a composite of ALI, major amputation, myocardial infarction, ischemic stroke, or cardiovascular death. And you can see that for every 10,000 patients treated, you save 181 of those endpoints, and you have an increase in bleeding by 29. So in summary, in patients with symptomatic PAD undergoing revascularization, 1 in 5 will have an event with acute limb ischemia, major amputation, myocardial infarction, ischemic stroke, or cardiovascular death at 3 years. And in Voyager PAD, Rivaroxaban, 2.5 milligram BID plus aspirin was associated with a 15% significant reduction of MALE and MACE, with no significant increase in TIMI major bleeding. ALI was significantly reduced by 1/3 compared to current standard of care, and the benefits, as I pointed out, appeared earlier and were consistent over time. It was also consistent across the major subgroups, and this treatment prevents 6 times as many ischemic events relative to the bleeds in PAD patients with after revascularization. So the dual pathway inhibition treatment is now the only antithrombotic regimen that is proven for significant benefit after peripheral revascularization in a large randomized controlled trial. Thank you. And Sebastian, it's now my pleasure to announce you to look at these data from a surgical point of view. And the question is really, can we avoid acute limb ischemia following surgical revascularization?
Yeah, thank you very much, Rupert. And following your general results out of this study, I would like to present now a large subgroup analysis focusing just on the surgically treated patients within this study. And of course, this is a very important question specifically to surgeons. Does this new antithrombotic treatment regime also apply to surgically treated patients for PAD? These are my disclosures due to this talk here. and this is actually the topic I would like to focus on for now. I actually can go over this slide because you already saw those figures and tables in both previous speakers. In conclusion, the major randomized trials looking for different options of antithrombotic regimen for surgically revascularized patients didn't show a benefit really for the one or the other treatment regime. So we still have this open question: how can we improve the outcome and the overall fate for our surgical patients? And as you have heard from Rupert, the Voyager study was randomizing patients being symptomatic for lead for receiving either Rivaroxaban, 2.5 milligrams twice daily plus aspirin, or just placebo treatment, so meaning aspirin 100 milligrams. And it was not randomized for the technique of revascularization. So surgery and endovascular treatment was not randomized. This is the reason why we have different overall numbers in those both groups. And as I may recall, the primary endpoint showed very positive results, accruing over the entire follow-up period, ending up with a positive number needed to treat of 39 patients following after 3 years. So the objective of this subgroup analysis was now to evaluate whether efficacy and safety as well of this treatment group for symptomatic PAD is consistent, regardless of the approach of revascularization. And we wanted to see a primary efficacy outcome as a composite of acute limb ischemia, major amputation, myocardial infarction, stroke, cardiovascular death, principal safety outcomes, and TIMI major bleeding is still efficient for all those different subgroups. And to evaluate this, we used this Cox model with interaction terms to assess the heterogeneity for efficacy and safety. The surgical group actually consists of 2,271 patients. So this is a large cohort representing roughly 1/3 of the overall group. 4,293 patients were treated endovascularly. And out of the surgical patients, 1,106 patients received bypass, 707 transfemoral endarterectomy, and 316 patients received a combination of both endarterectomy and bypass surgery. The baseline characteristics looking for surgical patients and endovascular patients revealed some differences between both groups. And as we can see quite well, the endovascular patients were slightly older and there were more female patients treated. In addition to this, there was a significant higher number of patients suffering from diabetes, hyperlipidemia, and chronic kidney disease. Nevertheless, more patients within the surgical group were current smokers. There were also significant differences in percutaneous coronary pre-interventions, which was higher in the endo group. On the other hand, also coronary artery bypass was also more often performed in the endovascular group. Accordingly, baseline medications differed in both groups. There were more patients pre-treated at baseline with clopidogrel, with dual antiplatelet treatment, and also with statins compared to the surgical group. In terms of geographical distribution, it is interesting to note that the vast majority of patients were treated in Eastern Europe. In the contrary, the endovascular treated group was mainly treated in Western and Eastern Europe with a almost similar distribution. The PAD characteristics, on the contrary, showed very interesting differences between surgical and endovascular patients too, meaning that patients treated surgically had a roughly higher PAD status than the endovascular group. So there were more patients being in a critical limb situation, 30%, comparing to 19.5% in the endovascular group. And there was also a different history of pre-treatment. The endo group was more often pre-treated endovascularly, and the surgical group was more often pre-treated surgically. In addition to this, the target lesion length showed differences between both groups again, and more patients treated surgically had long lesions, so long occlusions, compared to the endovascular group. We see here now the results of the primary composite endpoint containing acute limb ischemia, major amputation, myocardial infarction, ischemic stroke, and cardiovascular death. Very similar chart here as the overall group. However, the differences are even higher and more in favor of the Rivaroxaban group here in this surgical subgroup, meaning that over a follow-up course of 3 years, we have an overall positive number of needed to treat of 24. Remember, in the overall group, showed by Rupert previously, this number needed to treat was 39 patients. So this is even more effective in the surgical group than in the overall group, obviously. And also the different endpoint components containing of acute limb ischemia, vascular amputation, myocardial infarction, stroke, and death show significant differences in favor of Rivaroxaban use. Just the major vascular amputation doesn't show such a significant difference. Also, event-free survival with Rivaroxaban in surgical patients had a positive and over time accruing course, here again with a number needed to treat after 3 years of 26. Safety, as pointed out by Rupert, is a major issue. And we can see here that we do have some numerical differences in favor of aspirin use compared to Rivaroxaban plus aspirin in terms of tiny minor bleeding, bark bleeding, or ISTH major bleeding. However, no numerical difference in all the other subgroups, specifically in terms of fatal bleedings or intracranial hemorrhage. The procedural bleedings also didn't differ between both groups, and also any bleeding associated with a take-back or any revascularization procedure didn't show any significant differences between both groups. So overall, we have a very robust benefit over all subsequent sub-items in this study in favor of Rivaroxaban plus aspirin. The major fate of these patients and the adverse outcome is acute lip ischemia. And if we compare this negative outcome with cardiac patients receiving a myocardial infarction and look after the 1 year outcome after from both groups, we definitely see that patients with PAD and suffering acute lip ischemia definitely have a more fatal course after 1 year than the cardiac patients. Mortality at 1 year after cardiac event is after 1 year cardiac event is 8.1%, comparing to 12.1% after acute lip ischemia. Also, recurrent ALI is associated with a 24% recurrent ALI and 11% MACE event, and amputation rates 1 year after ALI is 27%, sky high. All those numbers are much less in the cardiac group. So this means we definitely have a high risk subgroup here in those patients. So it is, of course, very important to look after this subset of patients receiving acute or developing acute lip ischemia following this treatment course within the Voyager trial. This is why we looked for this subset of patients. And again, here, as we can see, the outcomes after ALI is really devastating, with 15% after a year unable to go home or even dying. Lower extremity revascularization is associated with acute lip ischemia. And this is a result coming out from the Euclid study, where we definitely saw that this hazard ratio is highest following prior lower extremity revascularization, which is definitely higher than following prior atrial fibrillation, low baseline ABA, age, and baseline statin use. And we see that the early time, 1 year following the event, is the timeline which is mainly affected for this devastating complication. So the method coming to the methods, ALI was prospectively ascertained and independently adjudicated by a blinding committee using an established definition. Sites were trained to identify ALI events, and we then performed this secondary analysis of the Voyager data, looking for the effect of Rivaroxaban, estimated again with the same Cox proportional hazards model. The baseline characteristics comparing patients receiving or developing ALI with patients not developing ALI showed some significant differences. The patients without ALI were slightly older than patients with ALI. We had more Caucasians receiving ALI. We had diabetes mellitus was obviously some kind of a protecting factor, because we had less diabetic patients in the ALI group. However, more current smokers in the ALI group, which was actually a very important finding here. And we also had less patients with clopidogrel use in receiving ALI compared to the non-ALI group. Peripheral arterial disease history showed also differences. We had, as we know from literature, more patients with a prior lower extremity revascularization in the ALI group, a significant difference between both groups. And also type of revascularization was also obviously associated with this. Surgical treated patients obviously had a significant higher risk here. Here we see the effect of Rivaroxaban on ALI, and again, very robust and similar to the surgical subgroup overall and the general group. Here we can again see that Rivaroxaban obviously has a positive effect on ALI. 7.8% is standing against 5.2% in the Rivaroxaban group, which is a highly significant and positive endpoint for the Rivaroxaban group. Early acute limb ischemia is also diminished after use of Rivaroxaban compared to placebo. 3.2% is standing against 1.7% here. And again, this difference is accruing over time. We have here a number needed to treat following 6 months of 67 patients, which is highly effective, obviously. We then looked for different subgroups here, and we see actually that all the different subgroups, independent of age, sex, kidney function, diabetes, coronary artery disease, and indication, showed positive effects, specifically, obviously, the elderly patients and also patients with a slightly decreased kidney dysfunction. And in addition to this, sorry for those switched numbers here, we see again that in the surgical, the endovascular group, independent of clopidogrel use, yes or not, Rivaroxaban showed a robust benefit compared to the placebo-treated group. And again, a reduction in early acute limb ischemia with Rivaroxaban, with and without clopidogrel. We don't see a significant difference between patients receiving clopidogrel or not receiving clopidogrel. So there is obviously no additional benefit for clopidogrel use in this study. So I summarize. ALI is the most frequent ischemic event after lower extremity revascularization for symptomatic PAD. It occurs early after lower extremity revascularization, and recurrent acute limb ischemia is very common. Rivaroxaban 2.5 milligrams twice daily with aspirin compared to aspirin alone significantly reduces the risk of ALI and is accruing over time. And the benefit of Rivaroxaban appears early, persists over time, and is consistent regardless of type of revascularization and use of clopidogrel. Thank you very much.
Thank you very much, Sebastian, for this excellent presentation. And also thank you for sharing these brand new data, which are unpublished yet. So very interesting data. And I think it's also important that you pointed out that the surgical group, it was not randomized between surgery and endovascular. Yeah. So the surgical group really had a more severe course of PAD or lead. I have a question from the chat to you. Do these data for Voyager also apply to other DOACs?
Yeah, that's a good question. And today we must say we can't support actually the use of other DOACs because this study was performed with Rivaroxaban. So I would strongly recommend to stick with Rivaroxaban for treatment of those patients in this indication actually.
Yeah, I think that's also the secret, to have really the right dose. It's a very low dose, and that was proven effective in COMPASS. It was proven in ATLAS, and so we don't have these data for other DOACs. Okay, thank you very much again, Sebastian. We move on to endovascular treatment. Professor Brodmann, Marianne, I'm happy that you talk about the difficult topic, clopidogrel, yes, no, and how long? Please.
Thank you very much, Rupert, that you assigned me to this topic, because it's difficult to talk about. Thank you very much. But nevertheless, I'm really happy that we also can cover this during this webinar, because we had a lot of good data already from Marco, from you, and from Sebastian, especially this ALI data. But what is a really hurdle for us in endovascular on an everyday basis is, should we add clopidogrel to aspirin, and now should we add clopidogrel to dual pathway inhibition concept? So the background for dual antiplatelet therapy in endo is, as a lot of other issues, is extrapolated from coronary interventions. So we don't have specific trials, and we don't have data which exist for PAT interventions. And this is really the third comment I want to make on this, is really something which should not be done in 2020, because most commonly the usage of dual antiplatelet therapy, so the add-on of clopidogrel, is done with regards to the instructions for use of the different devices of the respected institution. So with increase of new devices used in PAT interventions, this is really a weird story, because it's now something from 0 months to 12 months or even longer. So and I think this is really one aspect in the Voyager trial which has been proven very clearly what we should do with clopidogrel in our endovascular procedures. What do we know about dual antiplatelet therapy? We see for the peripheral arterial disease in the Charisma trial, where there was a symptomatic PAD was a subgroup, that when we added clopidogrel to aspirin, we had an advantage with regard to the efficacy, but also we had a disadvantage with regard to the increase of MACE, and this was clearly bleeding. And I think this is very clear, that if we add something to, or if we increase the dosage of anticoagulation or antithrombotic treatment, this might increase in a higher bleeding risk. Marco has already pointed out in his first talk very clearly the guidelines, the current ESC and ESVS guidelines from 2020. And in these guidelines, with regard to the data we have, we said that in percutaneous interventions, so in endovascular treatment, dual antiplatelet therapy should be given for 1 month, afterwards followed by a single antiplatelet therapy. This was due to the data we had at that time, and for example, surgical interventions, we did not recommend that. The Voyager trial, you already have seen this with regard to the study design. I just want to highlight that in the endovascular group, all kind of treatment options we have right now in 2020 have been evaluated in the endovascular group. So what we see here and what we discuss here with regard to the efficacy of this COMPASS regime, this vascular dose of Rivaroxaban plus aspirin, is really applicable to all kind of endovascular interventions today. And with regard now to the specific point of should we add clopidogrel or should we not add clopidogrel, with regard to the efficacy, we see that we have an advantage with regard to efficacy in the clopidogrel added group compared to the group without clopidogrel, but we also see that we have an increased bleeding in the clopidogrel group than in the without clopidogrel group. So should we leave clopidogrel away? No, we know that there is a certain time span when we can use clopidogrel as an add-on in long lesions, drug-coated balloons, drug-eluting stents, or whatever, and this is 1 month. So if we prolong the duration of this add of clopidogrel to the dual pathway inhibition, then we have the higher bleeding rate. So just let me summarize on this specific topic. The benefit of Rivaroxaban plus aspirin versus aspirin alone is consistent, regardless of the background of clopidogrel. The safety of Rivaroxaban plus aspirin versus aspirin alone is also consistent, but however, clopidogrel exposure was associated with higher rates of bleeding overall, particularly with longer durations, longer than 1 month. Thank you.
Thank you very much, Marianne. I think this is a very important topic. And again, as Sebastian pointed out earlier, also that is true for the clopidogrel subgroup, which clopidogrel was used in about 50%, but that was not randomized. I think that's important to emphasize. So you cannot compare the efficacy data or the safety data between those patients receiving clopidogrel and those who are not receiving clopidogrel, because it's just different patients.
I agree. But what we see here, because there's always the question, with regard to clopidogrel. Everybody's asking you, should we add clopidogrel or should we not add clopidogrel? I think this is the first study, and this is a study which is really representing modern and current endovascular therapy, that the add-on of clopidogrel should not go any longer than 30 days. I think if we get this kind of message, this is something which is really very helpful for us.
Yeah, very good. And Marianne, there are 2 questions now for you regarding tilostazol. And there's, what about the data for tilostazol for post-intervention? And another question is, what about in primary and secondary prophylaxis? Can you answer that? Tilostazol.
The issue is that we don't have in Europe any kind. I guess there is there's no country in Europe where we should use it. We have some data that it's efficient, but also once again with a higher bleeding rate. So I would not recommend it.
Yes, and I should note that in the Voyager trial, because it was allowed to use aspirin, it was allowed to use clopidogrel, and it was randomized to Rivaroxaban, so tilostazol was not allowed. And as you said, because many countries do not have it available, other countries use it, in Japan, for example, but unfortunately we don't have a good evidence for that drug, and nothing compares to a study with 6,500 patients. Sebastian, I would like to hand over to you now to announce the next presentation, please.
Yeah, we again come to Marco De Carlo, who will give his second presentation now on the endo patient with high bleeding risk, the antithrombotic approach in a polyvascular patient with a specific focus on highly bleeding risk. This is our main topic. And Marco, we are all very tensed what you will tell us now to this specific problem.
Thanks, Sebastian, and I'll try to be provocative. And just to start the presentation, I wanted to comment on the question that you just asked Marianne. Actually, there is no answer to many, I would say, to the majority of the questions that were raised about the use of clopidogrel, how long, and so on. Marianne said the only thing that I think can be safely said, do not give clopidogrel longer than 1 month, in addition to aspirin and Rivaroxaban. But we would need really lots of different trials to assess all the potential combinations of treatment. So what we need is also, the ability to judge when the risk of thrombotic complication is high and when the risk of bleeding complication is high. And then we can tailor the treatment. And the case that I'm going to present is really, I think, summarizes this complex situation. So this patient started his clinical history at the age of 50. He was an heavy smoker, he was obese, diabetic, he had depression, and also he suffered from Crohn's disease. So in 2017, he developed effort angina. So he underwent coronary angiography, and he was found to have a three-vessel disease with a three-vessel coronary artery disease with a chronic total occlusion of the right coronary artery. So he underwent PCI, coronary intervention, with implantation of 3 drug-eluting stents, and was discharged on dual antiplatelet treatment with aspirin and clopidogrel, plus high-dose statin and an ACE inhibitor. A few months later, he developed restenosis in the left anterior descending artery, so it was decided to proceed to coronary artery bypass grafting. And of course, before the intervention, he stopped clopidogrel, so he was operated on aspirin alone. Some months later, he developed lifestyle-limiting intermittent claudication at both legs, so he was found to have a very long bilateral occlusion of the SFA. And he was prescribed exercise because he was already on optimal medical therapy. The patient, being obese and depressed, did not exercise at all. So several months later, he came back. He had no improvement in claudication. So he underwent PTA, endovascular revascularization of the left SFA with implantation of 2 bare metal stents. So in December, 2 months later, he underwent the treatment of the right SFA. Now I'm showing you the images. You see there is some disease in the proximal SFA, then there is a long occlusion with a good collateral flow coming from the profunda femoris. So the revascularization was performed with a subintimal dissection. There was some difficulty in re-entering the true lumen, so we used a re-entry device. And following repeated inflations, the result was not very good, with a long spiral dissection with some limitation to antegrade flow. So it was decided to implant 3 stents, 3 nitinol stents. The final result was reasonably good. There was still some disease in the proximal SFA. Then, of course, the area of the stent implantation was good, and there was good also in the bent knee projection. So the patient was discharged on aspirin and clopidogrel for 6 months because he had received 3 stents in the SFA. So 6 months to antiplatelet therapy. A few months later, he complained of recurrence of right leg claudication, and he was found to have a mild in-stent restenosis in the SFA and was kept on medical therapy. After 6 months, he stopped clopidogrel as expected, but a few weeks after stopping clopidogrel, he developed sudden worsening of right leg claudication, and he was found to have an occlusion of the stent, of the proximal stent. So this was the image. You see that there is an occlusion, total occlusion, and the evidence of diffuse restenosis in several spots. But there was also thrombosis, so he underwent thrombectomy plus local thrombolysis overnight. But the results after thrombolysis was still not very nice. So a lot of restenosis, the thrombus had been cleared, but following repeated inflations, the result was not nice, and so it was decided to implant a drug-eluting nitinol stent in the proximal SFA, partially covering the in-stent restenosis. So, in this complex patient, we have now to decide what kind of treatment, anti-thrombotic treatment to give. So what is the clinical condition? He has a mild anemia. He has 11.1 grams per deciliter of hemoglobin. Because of his Crohn's disease, he had some blood loss from the bowel. He also had a mild renal failure with a glomerular filtration rate of 57 milliliters per minute. He, of course, had a severe coronary artery disease with previous CABG. He had severe lower extremity artery disease with diffuse and long occlusions and many stents implanted. And he already had both coronary and SFA in-stent restenosis. Additionally, he had also stent thrombosis in the SFA on aspirin treatment. So the question is, what kind of antithrombotic therapy should we give this patient? When we decide the antithrombotic treatment, as I said before, we should always balance the thrombotic risk versus the ischemic risk, the bleeding risk, sorry. So if we decide that the thrombotic risk, which means the risk of MACE, major adverse cardiovascular events, including death, MI, and stroke, plus male major adverse limb events, including acute limb ischemia and amputation. So if we decide that these risks outweigh the risk of bleeding, then we should go for a dual anti-thrombotic treatment for long term. On the other hand, if we deem that the bleeding risk of the patient is outweighing the risk of thrombotic complications, then we should go for a single antiplatelet treatment for long term. So how do we decide the bleeding risk of a patient? And being a cardiologist, let me support the efforts that have been done in the field of coronary interventions. And this is a paper, a consensus document published by both European and American experts, the so-called Academic Research Consortium, the one that also invented the BARC classifications for bleedings. So this was published last year in Circulation and the European Heart Journal. And high bleeding risk in patients undergoing coronary interventions is defined as the risk of major or fatal bleeding of at least 4% at 1 year, and the risk of intracranial hemorrhage of at least 1% at 1 year. So it's really a high risk of major bleeding. So there are some major criteria and some minor criteria for bleeding risk. Major criteria are those that in isolation confer this high risk, and minor criteria are those that in isolation do not give such a high risk alone. And by definition, a patient is at high bleeding risk if he has at least one major or two minor criteria. So what are these criteria? Here you have the whole list, and I suggest that you familiarize with these criteria because these are now adopted in the ESC guidelines, for example, for non-ST elevation acute coronary syndromes. And it's a very straightforward evaluation, very simple evaluation of the presence of major criteria, such as, of course, the need for long-term oral anticoagulation, but also severe or end-stage renal failure with a GFR below 30, or anemia with a hemoglobin below 11 grams per deciliter. But I want to stress there are some minor criteria which are very often encountered in our patients, particularly in patients with lower extremity artery disease. In fact, age above 75 years is a minor criteria, as well as moderate CKD with a GFR between 30 and 59. So if you put these two together, you have high bleeding risk. So how many patients that you treat every day are above 75 and have a GFR between 30 and 60? Additionally, hemoglobin between 11 and 13 for men and 11 and 12 for women is also a minor criteria for high bleeding risk. And if this applies to coronary intervention, it also applies to lower extremity intervention. For example, in this patient who was very young, but he had moderate CKD and a moderate anemia, it would qualify as a high bleeding risk based on these criteria. Once we have defined the bleeding risk, we also have to define the thrombotic risk. And again, in the coronary field, we have a very clear classification of the thrombotic risk, which is, again, in the guidelines, in the 2020 guidelines for non-ST elevation coronary syndromes. And you see that high thrombotic risk encompasses the definition of complex coronary artery disease plus one risk enhancer, at least one risk enhancer. And there are some clinical and some technical risk enhancers. What are they? Look, diabetes, history of recurrent MI, multivessel coronary artery disease, polyvascular disease, which is the association of coronary and peripheral artery disease. So, for example, this patient had complex coronary artery disease plus diabetes plus multivessel coronary artery disease plus polyvascular disease, systemic inflammatory disease. So you see that this patient had a lot of risk enhancers. So it was certainly at high thrombotic risk. In addition to the clinical risk enhancers, there are also some technical risk enhancers. And these are the number of stents implanted, the total stent length, and the history of complex revascularization. And again, the patient I'm talking about had at least 3 stents implanted, had a total stent length of more than 60 millimeters, had a chronic total occlusion. Additionally, if we can, let's say, translate from coronary to the lower extremity artery disease field, this patient had also a history of stent thrombosis in the SFA while being on antiplatelet treatment. So this patient is really high thrombotic risk. So in summary, a patient can have both a high bleeding risk, like my patient, with moderate anemia plus moderate CKD, and at the same time a high thrombotic risk with complex coronary artery disease, with multiple clinical and technical risk enhancers, as I showed you before. But he also had severe lower extremity heart disease with, again, multiple clinical risk enhancers and multiple technical risk enhancers for both coronary and peripheral artery disease. So, and now I ask you, all the attendees, if you want to vote, to express your preference for this therapeutic alternative. So there are three options that are possible, in my opinion. The first one, option number one, is to give the patient a dual antiplatelet therapy with aspirin plus clopidogrel for, let's say, from 1 to 6 months, and then go on with clopidogrel monotherapy if we decide that the bleeding risk of the patient prevails over the thrombotic risk. Option two, we should go for dual antiplatelet therapy with aspirin and clopidogrel long-term, as it is possible for coronary patients based on the guidelines, but also for peripheral artery disease patients, this could be an option. And finally, option three, dual antithrombotic therapy with aspirin plus Rivaroxaban low dose for the long term. So if you want to vote, you can express your preference for one of these three options. I think that all of them are quite reasonable. I don't know if Rupert wants to comment while we wait for the results of the voting. What will be his choice?
Marco, this is a great case, really, because it shows you that everything in real world is not exactly the same like a randomized patient in a study. For the viewers, if you want to get to the vote, leave the full screen mode of your computer or your handheld device and enter. And while we're waiting for the answers, Marco, I'm impressed with that patient, really, because obviously this patient has a very strong thrombotic tendency. And I would be also curious, because of his Crohn's disease, he has high factor VIII, high fibrinogen, he has a strong hypercoagulation. He may have even received cortisone. And so I would also ask about this history and the situation. Was this acute Crohn's disease? And because you saw, a very thrombotic vessel in that patient. And that's, I don't want to take the answer here, but I'm concerned about the high thrombotic risk. And the other thing that I liked in your presentation is that you showed that those patients that have a high bleeding risk, unfortunately, are always the ones who also have a high thrombotic risk. If this is renal impairment, for example, if it's diabetes, if it's polyvascular disease, that's always the problem. And so, here we have the result, and I can read it to you. So option A was dual antiplatelet treatment, aspirin and clopidogrel for 1 to 6 months. That was 22%. 10% selected dual antiplatelet treatment long-term, and 2/3 really selected the dual pathway inhibition with aspirin and Rivaroxaban. Perhaps they were, kind of triggered by the high thrombotic risk. Marco, do you want to comment on that result?
Yeah, sure. The first thing is that I agree that there is a little evidence to support aspirin and clopidogrel for long-term treatment. Also in the coronary field, actually, the data that we have are at the longest are for 3 years. So there is really no background to give aspirin and clopidogrel long-term to any patient, because we don't know if it is effective in the long term. So this is the first point. The second point is that I see that quite a good proportion of the attendees have chosen to go for a single antiplatelet therapy for the long term, because they were probably concerned by the bleeding risk, or probably they are not so much convinced by the data on Rivaroxaban plus aspirin. But I must say that if I have to pick a patient for this, let's say, Compass regimen or Voyager regimen, this is exactly the patient I would choose, because he's a terribly high thrombotic risk. And we have seen that he had stent thrombosis on aspirin treatment alone. So really, this patient, as you said, has probably a very thrombotic milieu, probably also linked by this systemic bowel inflammatory disease with Crohn's disease, that he had, of course, this relapsing disease with some, of course, blood loss, and that was the cause, reasonably the cause of his anemia. And of course, this patient was always on antiplatelet therapy, sometimes with dual antiplatelet therapy, so it was bleeding more. So it's very difficult to choose which option is better. But what we can say is that the patient can do well with a mild anemia, but the patient is going to do very, very bad if he has recurrent acute limb ischemia, if he has recurrent MI. So I'm a little bit, afraid of those so-called net benefit endpoints when you put together endpoints like death, MI, stroke, and major bleeding, because major bleeding is, of course, something that you should be worried about, but it's not the same as having a stroke, and it's not the same as acute limb ischemia, it's not the same as having myocardial infarction. So I think that really in this patient, when both risks are contemporarily present, I would weigh more the thrombotic risk, particularly considering, and I'm finished, I'm particularly considering that the increase in bleeding risk with the Rivaroxaban low dose is really minor increase.
Yeah, and I think this is also an important remark that you said. It really depends on the dynamics. So it's not a decision for long term. You have to really follow the patient and see how he's doing, and then perhaps re-evaluate your decision. A short question to you, that's from Ljubljana in Slovenia. Are there any criteria for thrombotic risk in PAD similar to the ones that you showed for CAD?
No, there aren't, to my knowledge. What I suggest really to all of you, to all our community, is we could just try and validate these both these scores, the high bleeding risk score and the high thrombotic risk score, which are very, very simple to assess in a cohort of patients undergoing lower extremity artery revascularization, because that would save a lot of time in terms of finding new scores. But I think that really these patients have many things to get in common. So I think
that's a very important remark. And we saw from Voyager for the first time in a large prospective trial that no matter what kind of subgroup, but the event rate is extremely high, 20%, 25%, even higher. So we don't need to identify subgroups. The overall patient after revasc has a very high risk. We are running short of time, but Sebastian, before we start with the next presentation, there is a question to you for your presentation. Would you recommend aspirin and low-dose Riva after infraguinal prosthetic bypass?
Well, yes, I definitely would recommend it, and I definitely do it in my institution here, as those patients usually represent a high general risk for cardiac and also limb events. Those patients usually have a multi-site located atherosclerosis, and as we know specifically from those patients, this new treatment regimen is of high benefit for those patients. So in general, I would definitely recommend this combination. Yes.
Okay.
Yeah, I think we should go on. And Rupert, we are good in time, and you are now on for the next talk on specific risks for the redo patient. So we do have specific clinical situations here now we want to cover with specific talks, and we all have to treat with revascularizations and redos, and it is very interesting now to hear what we should do with those patients. Rupert.
Yes, in fact, thank you very much. In fact, that's something that we often, of course, have, that we have a patient undergoing revascularization and the patient comes back. So in that example, we have a 74-year-old former school teacher, and she had a PTA of the SFA 3 years ago. She also has metastatic breast cancer, which is more or less stable. She has impaired renal function, which is very common. You see the GFR is 31. and that's her medication. She's on aspirin, a statin. That was 3 years ago. And now, last week, she comes back with subacute ischemia of the left leg. She now has claudication after only a few steps. She has paresthesia, nocturnal rest pain, no pulses palpable. And if you look at the plethysmography, there is 0 line on the left leg. And if you look at the ankle brachial index and the pressures on the left leg is very, very low. So it's a critical ischemia. And the ultrasound shows you a very narrow stenosis and a narrowing of the SFA. And of course, this patient had to go to the cath lab, and here you can see the angio, that's before PTA, and you can see there's an occlusion of the SFA, very narrow thrombotic material here. And she was successfully recanalized, what you can see here. She also received a stent. And now the question is, what do we do for the antithrombotic treatment in that patient? What are the data? And again, I think Voyager is such an interesting, important study because it tells us much more, even beyond Rivaroxaban. If you look at the control in the placebo group, you can see that in the placebo patients with no prior limb revascularization, the event rate is 17.7%. If we look at the aspirin and clopidogrel group on the patients that had a prior lower extremity revascularization, you can see that the event rate again is higher. It's 23.8. So the event rate increases by more than 6% if the patient had a revascularization before. And that's the aspirin group. And again, I want to remind you that 50% of those patients also had clopidogrel. So that's data independent of Rivaroxaban. Now, how about Rivaroxaban? As I pointed out, those patients with prior lower extremity revascularization have a high event rate, and that was significantly reduced with the low dose of Rivaroxaban by absolute risk reduction 5.7%, numbers needed to treat 18. So a very, very effective treatment. And now if we compare those patients without prior revascularization and those with prior revascularization, you can see that especially acute limb ischemia is very high. It's more than 10% in the study. And that's even though the patient received aspirin and half of the patient received clopidogrel. And you can see there was a significant reduction hazard ratio, 0.59, so more than 40% risk reduction with the addition of Rivaroxaban. And again, also the vascular amputation was reduced, even though not significantly. How about the bleeding? If you look at the patients with no prior limb revascularization, as we saw earlier, there was a numeric increase in the bleeding risk. However, in those patients with a high thrombotic risk receiving Rivaroxaban, there was no difference in the risk of major bleeding in those patients compared to placebo. And again, no difference, significant difference in those patients with respect to intracranial or fatal bleeding in both groups. If we look at those more sensitive bleeding parameters, ISDH major bleeding was more in those patients with prior lower extremity revascularization, but that was not significant. So in summary, for that important subgroup that we see commonly during everyday practice, the patients with recurrent lower extremity revascularization versus those undergoing first LER, they have a higher rate of ischemic events, particularly acute limb ischemia. They derive an even greater benefit of Rivaroxaban for the composite of acute limb ischemia, major amputation, myocardial infarction, ischemic stroke, or cardiovascular death, and the greatest absolute benefit was observed for acute limb ischemia. The safety of adding Rivaroxaban to aspirin and clopidogrel is consistent regardless of the patient had a prior lower limb revascularization or not. So for that patient, she was successfully recanalized. We used aspirin. We used clopidogrel for 4 weeks because as we saw earlier, after 4 weeks, the risk of bleeding increases if you extend clopidogrel use and Rivaroxaban 2.5 milligram BID. Thank you very much.
Yeah, Rupert, this is a great message again, and also underlining actually all other results and highlighting the benefit, overall benefit of our patients receiving this dual pathway treatment. And I think this is very worthwhile to realize, and we should be aware of this specific situation in this specific subset of patients who has a very high risk of acute cardiac and also limb events. And we can prevent both situations which are very devastating for our patients.
Sebastian, may I ask you a question from the chat here? Again, practically, do you routinely use Rivaroxaban 2.5 milligram twice daily now after Revasc?
If this question goes to my side, yes, I would say we routinely use this new dual pathway treatment regimen now. Yeah.
And I guess also to Marianne, because you are now having the next case here, the special risk of critical limb ischemia. How would you answer this question? Do you routinely use Rivaroxaban 2.5 milligram twice daily plus aspirin?
We would do it if it would be reimbursed, but what we do in the meantime is that we at least patients who are coming back and have a revascularization, we urge the insurance companies to pay for that. So this is the situation right now in Austria.
Yeah, it's different in different European countries at the moment. Okay. But Marianne, as we have you here, may I ask you about your next case, the special risk of CLI?
Yes, thank you very much. So this is now the last topic here in this webinar, the special risk of CLI. The burden of CLI is really very outstanding. The annual incidence of CLI has been estimated at 220 to 3,500 people per year, and this is approximately 1% of the adult population. And up to 10% of patients with PAD may have CLI, and not only symptomatic PAD patients will progress to CLI, also asymptomatic PAD patients can progress to CLI. These are data from Conti's paper in 2009, and he was first time showing that between 5 and 10% of patients with asymptomatic and up to 30% with intermediate claudication will progress to CLI over a 5-year period. And we will face a higher percentage of patients with CLI in the upcoming years due to the lifestyle. Given the aging of the population in general, the global increase in metabolic syndrome and the ongoing effects of diabetes and smoking, the prevalence of both PAD and CLI is predicted to increase. And these patients are at high risk from limb events and high risk for cardiovascular events. And so I would say within the spectrum of PAD, CLI represents the end stage of PAD. Without revascularization of more than 40% will suffer limb loss within 6 months, and 27% to have one amputation will have a second one within 1 year. High mortality risk, 24% within 1 year and 60% within 5 years. Higher than 5-year mortality risk of most cancers. So we fear cancer, but we should be afraid of CLI. This is my personal opinion. What should we do to overcome the burden? We need to restore the blood flow. This is one thing we all of us are focused on, doing endovascular surgical procedures, reopening the vessel. CLI has been the focus, therefore, of interest in innovation in the last years. There is a huge impact of new technologies and progress, but revascularization in any way is only good if the result is long-standing, and to stop the progression of the disease and add on to a specific device is needed. And this is, in my opinion, the best antithrombotic treatment. And we saw already in the COMPASS trial that there's an advantage for the development of acute lymphemia or chronic lymphemia by this regime. And this is, once again, I want to highlight that in the COMPASS trial, it has been able to show that the Rivaroxaban vascular dose plus aspirin significantly reduced also major amputations, all vascular amputations, and all lymph events. And the absolute benefit of the Rivaroxaban vascular dose plus aspirin was highest in the high-risk groups. And these high-risk groups, when we look at the what these high-risk groups mean, vascular disease in more than 2 vascular beds, history of heart failure, impaired renal function, or history of diabetes. This is the risk profile of patients with CLI. So it's clearly that CLI patients might benefit the most. And this was already shown in the COMPASS trial. You see a risk reduction with regard to chronic lymphemia, minus 33.3%, minus 44% of acute lymphemia, and minus 60% of all vascular amputations, minus 70% of major amputation. And in the Voyager trial, there was 1/3 of the patient, 20%, around 20% of the patients had critical lymphemia. So this was also represented in this trial. And you see here, with regard to this really good amount of patients with critical lymphemia, you could see that the primary endpoint was once again in favor of this vascular dose of Rivaroxaban and compared to aspirin alone. So once again, the reduction of the primary endpoint also in a cohort which included critical lymphemic patients. And when you look at the secondary outcome, once again, clearly this significant impact of the dual pathway inhibition to prevent or to improve these secondary endpoints. So how to overcome the burden of CLI? The dual platelet inhibition reduces the risk of CLI development and helps to prevent amputation in chronic PAT patients. Dual pathway inhibition provides better outcomes in CLI patients with necessity for any kind of revascularization, and therefore provides excellent vascular protection also in CLI patients. Thank you very much.
Marianne, thank you very, very much. And again, pointing really how important CLI is. I really like that the comparison to cancer. And I think we have to do a lot of awareness work here. We know that because those patients, we see them, but I think out there, unfortunately, there is still a lot to do. And now we have for the first time a drug that is really reducing that complication.
And maybe I can add something. You know, we were discussing about the high bleeding risk, and a lot of CLI patients might be assumed to be patients with high bleeding risk, and therefore I think it's really important to emphasize that CLI patients also had a benefit of this dual pathway inhibition, and not to keep this kind of regime away from them and say, okay, they at high risk of bleeding, so we only stick with aspirin alone.
Yeah, Marianne, there's a question for you from the chat here. Why do you think most interventionalists are not using this protocol? There still seems to be not convinced and concerned about bleeding risk. How do you want to comment on that? Why is it not, used more often?
You mean the
dual pathway inhibition? Yeah.
The issue is, first of all, in my opinion, there is still in the back of their mind that aspirin alone is enough. Second, if they want to improve the outcome, then they add clopidogrel, not thinking that this is increasing the bleeding risk. And this is really a paradigm shift that we should focus on this dual pathway inhibition in whatever kind of revascularization. But this needs education, and this needs more and more education just to convince our colleagues to do this.
Yeah. And now we have, for the first time, really evidence based on a large number of patients. Perhaps
and
a final, yeah?
It's a randomized controlled study. That's the point.
Yeah. Before I hand over to Sebastian, question for Marco. Is there any data regarding aspirin resistance and its impact on vessel patency? Aspirin resistance and its impact on vessel patency.
Well, not in the field of lower extremity artery disease. Mainly from the coronary field, we have lots of investigations, lots of data about mainly the resistance to clopidogrel, which is known from a pharmacological point of view to be very, very frequent, with about 1/3 of the patient who are not really good responders to clopidogrel. Nevertheless, all the trials that evaluated the strategies where the resistance to clopidogrel was specifically investigated before giving the clopidogrel treatment actually failed to demonstrate any benefit with a strategy of testing for clopidogrel resistance. So in the end, what I can say, what my let's say my take-home message from these trials on resistance to antiplatelet treatment is that it's not so important to find out if the patient is resistant, because really with one of the two antiplatelet working, most of the need of antiplatelet treatment are covered. And in the coronary field, there is now a clear trend towards giving a single antiplatelet, be it either clopidogrel or ticagrelor or even aspirin alone after stent implantation in coronary arteries, because with current stents, with current implantation technique, the risk of stent thrombosis is going lower and lower, below 0.5%. So I think that we should not really insist on two drugs that act on the platelets, but rather choose a strategy that combines both anticoagulant and antiplatelet treatment.
Yeah, important. And there are studies looking at patients who were aspirin resistant, and then they educated the patient, and so the percentage was lower, and then finally they had to take the aspirin while they were in the lab, and there was no aspirin resistance anymore. So it's again adherence, and we have to speak with the patient why he or she should use that particular drug for primary or secondary prevention. I hand over to Sebastian, please.
Yeah, I fully agree. And I think we should, at the end of this webinar, highlight a couple of points. First of all, the Voyager study obviously is a landmark study, which has brought us so much of new knowledge, which is so important and of such a high benefit for our patients. And it's probably one of the most important studies ever done within the last years, specifically on PAD patients. However, we should be aware about the drugs we used in this study. This was aspirin and Rivaroxaban in this specific combination. And this just doesn't allow us to change those drugs to similar drugs. So the study was used with aspirin and not with clopidogrel, and it was used with Rivaroxaban and not with another DOAC. So I think that's important. But overall, if I would try a summary on the most important overall results out of this study, I think we can conclude first that Voyager revealed a very robust and a overall benefit for all subgroup of patients in favor of this new dual pathway inhibition pathway, irrespective of patients receiving endo treatment or surgery, receiving treatment for ALI or CLI or for claudication, or irrespective of patients receiving their first treatment or redo treatment. All those subgroups showed very robust and over time accruing benefits for the Rivaroxaban group. Actually, the curves are always very similar in all subgroups. The second topic probably is we overestimated the risk of bleeding, obviously, when planning the study. That's why we started this study drug quite late, between 4 and 6 days, specifically relating to the technique of revascularization. Although we know that most acute events occur within the first days after treatment. So we probably could be even more frank with the starting point of this treatment. We even may consider to do our reconstructions under dual pathway inhibition use. So starting already before the procedure. This is a suggestion, of course, is not supported by the trial, but we can realize that bleeding risks obviously are not that high following this treatment combination. And the third topic, which was also novel and not expected by the executive committee, are the results of the subgroup of patients receiving clopidogrel in addition to this treatment, because we finally had to realize that at least in this study population of Voyager, clopidogrel was not of additional benefit for our patients. So questioning the additional use of clopidogrel, and we finally would conclude that if we think we need clopidogrel, we should terminate it as short as possible, ideally for 4 weeks. I think these are probably the most important remarks out of the study, although I know I can't conclude this within two minutes. We try to highlight many subgroups, and we will remind you all that many more subgroups will follow within the next months. And stay aware of everything which will be published out of the Voyager study. I'm very sure it will stay on to be very interesting. Thank you very much for your attendance. And thank you very much for staying with us. And please keep your interest. And I think it will be of benefit for all of us, especially for our patients. Thank you very much.
Thank you.
And thank you, everybody, for the speakers. Rupert, for your great moderation, as always. It was a great 90 minutes.
Thank you.
Thanks.
Thank you.
Yes.